Hello, I'm Dr. Christopher Thompson from Brigham and Women's Hospital and Harvard Medical School, and I'm honored to speak on primary endoscopic bariatric and metabolic therapies at this year's annual meeting. Obesity can be defined as the state of being well above one's expected normal weight. However, I think this is not terribly accurate, and perhaps a better way of looking at it is the state of the adipose tissue. And what you see here is an enhanced scanning electron microscopy image of an adipose tissue biopsy from someone with obesity. And you can see several adipocytes here. And what you notice is they're surrounded by activated macrophages. So this is chronically inflamed adipose tissue, and this is what is characteristic of obesity. This slide further illustrates the differences between healthy adipose tissue here on the left and chronically inflamed adipose tissue from a patient with obesity on the right. On the left, we have relatively small adipocytes, and they secrete innocuous cytokines such as IL-10, IL-4, and IL-13. And on the right, we have rather large adipocytes with a central apoptotic adipocyte here in crown-like structure. And we have activated macrophages again, mast cells, various T cells, including natural killer cells, foam cells. And this tissue secretes adipokines and rather toxic cytokines, including TNF-alpha, IL-6, and IL-1 beta. And of course, these circulate throughout the systemic circulation, causing the problems we see associated with obesity, such as CNS disease, fatty liver, type 2 diabetes, and vascular disease. And these conditions, of course, are part of metabolic syndrome, where we have at least 3 of these conditions or more, including hypertension, hypercholesterolemia, essentially type 2 diabetes and fatty liver with a high triglycerides there, and obesity. And this condition is becoming pandemic, with at least 30% of most nations' populations now suffering from metabolic syndrome. And the treatment of choice for these conditions is, of course, weight loss. And there's several studies that have shown this. And the Look Ahead trial showed that a sustained weight loss of 6% total weight was associated with greater long-term reductions in glycosylated hemoglobin and greater initial improvements in fitness and all cardiovascular risk factors except LDL. And the mainstay of treatment for NASH is also weight loss, with studies showing a correlation between weight loss and improvements in histologic features of NASH, with 7% total weight loss being required to show improvements in steatosis and inflammation, and 10% total weight loss being required for regression of fibrosis. Surgery is also very effective at treating these conditions, and here we have the results of the Stampede Trial, which was a 3-arm RCT carried out at the Cleveland Clinic that enrolled 150 patients with obesity and type 2 diabetes, and they randomized them to medical therapy, sleeve gastrectomy, or gastric bypass. And the primary outcome here was treatment success at 1 year, defined as a hemoglobin A1C of less than 6%. And only 12% of patients in the medical therapy arm achieved that goal, whereas 37% of the sleeve gastrectomy patients did and 42% of the gastric bypass patients. Additionally, there were just much greater drops in HbA1c in the surgical groups compared to the medical therapy group. And with that background, we'll move on to endoscopic bariatric and metabolic therapies, or EBMTs. And these break broadly down into 2 categories: gastric or small bowel devices. And the gastric devices are seen here on the left, including intragastric balloons, which are your space-occupying devices, gastric remodeling, including suturing and plication, aspiration therapy, and flow-altering devices. And these treat weight first and foremost. They treat obesity, and they have secondary effects on comorbid illness. And on the right, we have our small bowel devices, including various bowel liners, duodenal mucosal resurfacing, and anastomotic technologies. And these have direct metabolic effects and stronger anti-diabetic effects and lesser degree of weight loss typically. And there are no small bowel devices approved by the FDA at this time. However, there are several gastric ones, and we'll focus on these primarily. What about mechanisms of action? Well, not entirely clear. However, we do know that intragastric balloons have a space-occupying or space-filling effect, so people get full earlier and stay full longer. They also do induce gastroparesis, and they could, in fact, suppress ghrelin levels. Suturing may go either way. There's some studies suggesting it delays gastric emptying, similar to intragastric balloons, and others show that it might make it more rapid. And aspiration therapy works by other mechanisms as well. And then we have our small bowel procedures, such as the liners and magnets, which we know do spike GLP-1, having similar mechanisms to some of the hindgut procedures you might see in medications. And duodenal mucosal resurfacing is thought to have foregut effects. There are currently 2 intragastric balloons approved by the FDA, a fluid-filled balloon and a gas-filled balloon. And indications are class 1 obesity with at least 1 obesity-related comorbidity or class 2 obesity. And the contraindications, of course, are any prior gastric surgery, even a Nissen. That's where we get our complications and large hernias. So these are the approved balloons. There are a couple others on the way. There's a procedureless balloon that you can, the patient swallows and passes on its own a few months later. And there's the adjustable gastric balloon, which should be having FDA approval soon. It did have a successful trial. And then, of course, our flow-altering procedures. And here we have a meta-analysis looking at the clinical outcomes of balloons. And this included over 20 studies with over 1,600 patients. And the percent total weight loss at 12 months was 11.27%, so quite good. And this was across the board, even at the higher BMIs. How about its effect on obesity-related comorbidities? Well, this is another meta-analysis, including 10 RCTs and 30 observational studies in over 5,600 subjects. And overall, the HbA1c decreased by 0.6%. But if you look at patients with diabetes, the percent drop was 1.1, so pretty substantial there. Additionally, there was improvement in waist circumference by 4.1 centimeters and improvement in fasting blood glucose, hypertension, LFTs, and dyslipidemia, all of which were statistically significant. SAE rate was 1.3% with 5 gastric perforations and 2 deaths, for a mortality rate of 0.04%. And this was in patients with prior gastric surgery. So we're going back to that again. You do not want to place these in anyone with prior gastric surgery. How about balloons in Nafld? Well, this is a prospective series of 21 patients with early stage liver fibrosis. And at 6 months, the patients had 11.7% total weight loss. And here are their liver-related outcomes. On the y-axis, we have percent change in our various categories here. There's a 3-point median decrease in NAS, and fibrosis improved by 1.17 stages, and MRE detected fibrosis improved by 1.5 stages. Of note here, percent total body weight loss did not correlate with reductions in NAS or fibrosis. How about the long-term results? Well, this was a prospective open-label study of 500 patients with 5-year follow-up, and 26 patients were excluded after the first 6 months due to protocol violations, and then 17% did not make it into the study because they didn't achieve at least 20% excess weight loss. So this is responders we're looking at as we follow them out longitudinally for 5 years. Only 20% of those responders maintained at least 20% excess weight loss at 5 years. So pretty dismal if you use a balloon by itself, but probably a better way to do this is to combine balloons with medications or potentially use repeat balloons or other therapies. Moving on to gastric remodeling, and these endoscopic procedures follow 2 surgical analogs, either the vertical banded gastroplasty or a gastric imbrication focusing on folding in of the greater curvature. And these are best characterized right now, so we'll focus on the imbrication analogs. The first time this was done was in 2008 when we worked together with the Cleveland Clinic to perform this procedure using a suction-based suturing device. We studied 18 patients and we achieved a 27.7% excess weight loss. If we looked at smaller BMI categories, we had a 30.5% excess weight loss. So not horrible results, but durability was not there. Fortunately, in 2012, we obtained access to a full thickness suturing device, and together myself and Rob Hawes performed the first in-human ESG procedures. And we started in India and then expanded to Panama and the Dominican Republic and enrolled a total of 126 patients. And you can see the average BMI drop here was from 36.2 down to 29.8. And the percent total weight loss was roughly 20. So substantially better than those earlier results. And these results have been replicated. This is a study by Reem Shariah at Cornell. She had a prospective series of 91 patients and followed them up to 24 months. And the percent total weight loss was 20.9% at 24 months. And SAE rate 1.1% with 1 perigastric leak and no deaths. She also looked at comorbidities and found improvements in HbA1c of about a point, improvements in blood pressure, triglycerides, as well as liver tests. She followed this up with a 5-year study looking at 216 patients, and 68 were eligible for 5-year results. And you can see here, they again lost about 15.9% total weight at 5 years, and 90% maintained at least 5% total weight loss, and 61% maintained 10% total weight loss, and 27% of these patients were started on pharmacotherapy. Again, the adverse event rate about 1.3% with no fatal adverse events. So those were all done with the original triangle suturing pattern, and now we have several new patterns, and probably the most common one being used right now is the U pattern. You may also reinforce or not reinforce these, and number of sutures varies as well. And this is a study looking at that. We had 7 centers, and there was varying experience, with our center being the most experienced, and then another with moderate experience, and the rest were very new at the procedure. And we found that the percent total weight loss across the entire group was 15.06, and that was uniform. So all centers had at least a 10% total weight loss, and particulars of success here were age less than 40, male sex, and higher BMI. SAE rate, again, right around 1%. So this is encouraging. The results are certainly generalizable. This is a meta-analysis of 8 studies over 1,700 patients looking at ESG, and the percent total weight loss was 16.5 at 1 year, and the serious adverse event rate was 2.2. What about ESG's effect on Nafld? Well, this is a prospective registry study looking at 118 patients. They had a 15.5% total weight loss at 2 years, and here are the liver-related outcomes. Hepatic steatosis index scores decreased by 4 points per year. That was significant. Nafld fibrosis score also decreased by 0.3 points per year. And if you look at baseline versus at the end of the study here, these are the percentage of patients in each of these categories. You have your F0 to F2, F3 to F4, and a determinant in the middle here. And clearly, we're having a shift from baseline to the end of the study, when more people ended up in the category of F0 to F2 and less being indeterminate or in F3 and F4. So very encouraging early results. Now, gastric plication is different than gastric suturing in that we're not opposing mucosal layers, but we're opposing serosa. And here you see tissues pulled into these graspers, and a hollow needle is passed through the graspers with tissue anchors passed through that hollow needle distally, and the needle's withdrawn, and then a second basket is dropped proximally, and then that is cinched together, creating these serosal plications. This was then studied in a randomized sham-controlled trial and did not do terribly well, unfortunately, having only a 4.95% total weight loss. This was better than the sham control. However, it did not meet its endpoints. Now, this was focusing primarily on the fundus. And ESG, of course, focuses on the body of the stomach. And here we have a new version of this procedure called the distal pose, or pose 2.0, and again focusing on the body instead of the fundus, and we're getting much better weight loss with a 15% total weight loss at 6 months and approaching 18 to 20% at a year. We have data out of Spain on this procedure as well, 75 patients, and they had a 17.8% total weight loss at 12 months, so very encouraging. Additionally, they looked at all different classes of obesity, and it looked like the larger a patient was, the more weight they lost, so quite encouraging. And this just illustrates that last point, with higher BMIs losing more weight. So here is class 3 obesity losing 20%, whereas class 1 was only losing about 15%. Moving on to aspiration therapy. And basically we have a PEG tube here with a long fenestrated drain going up into the fundus. This is used to lavage the stomach about 20 minutes after a meal. And this is a randomized control trial, 2-to-1, aspiration therapy of the lifestyle, and the BMI range goes all the way up to 55. This was successfully placed in all but 2 patients. One had varices and one had a gastric bypass. We had co-primary endpoints here in this trial. The first was mean percent excess weight loss at 52 weeks, and it had to be above the control group. And you see in the modified intent to treat analysis, there was over a 30% total excess weight loss in the treatment group, less than 10% in the control group, and that was large enough to meet with FDA approval. And the second co-primary endpoint was a responder rate. At least 50% of patients in the treatment group had to have at least 25% excess weight loss. And again, in the intent-to-treat analysis, you see them breaking that 50% line right there, and the control group was nowhere near it. So this is FDA approved and available. What's unique about this is the longer you use the device, the more weight you lose. So unlike other devices where they tend to plateau earlier. And this is a 4-year follow-up study to that trial. And you can see here these patients are the ones that are still continuing to use it, are approaching 19% total weight loss. As far as the adverse events go, really no electrolyte or eating disorders, no issues there, but the one to watch out for is persistent fistulas. And 2.1% did require surgery, so something to be aware of. Moving on to small bowel devices now. Again, stronger anti-diabetic effects. To understand these, it's important to understand the incretin effect. And this graph illustrates it. On the Y, we have insulin production, and on the X, we have time. And this is where you give a patient a certain amount of glucose intravenously, and they make a set amount of insulin. You give them the exact same amount of glucose orally, and they make much more insulin. And that is the incretin effect. It is due to the release of hormones from enteroendocrine cells in response to food, short-chain fatty acids, or secondary bile acids. And in type 2 diabetes, this effect is blunted. So surgery tries to reconstitute this kind of normal response. And that's what we're trying to do with endoscopic therapies as well. So here's an example of an incretin, GLP-1. You know, this does a lot of things other than just increase insulin production. It crosses the blood-brain barrier and improves satiety signaling. It slows gastric emptying, responsible for some of those side effects for the medications, actually. Decreases glucagon production. So it does a lot. And it also is effective at helping trigger some weight loss. Another important concept to understand is Foregotten Hindgut theory. And here the white dots represent incretins, and they get denser the lower down you go. There's more in the distal bowel and colon. And these black dots represent an anti-incretin factor that's less well characterized. You see gastric bypass down regulates the anti-incretin signaling and up regulates the incretin signaling. That's the theory, at least. The duodenal jejunal bypass liner attempts to do both of these things as well. It shelters the duodenum from food, and it dumps bile and partially digested food distally, augmenting the hindgut mechanisms as well as working on foregut. This is a meta-analysis looking at the use of the liner in patients with obesity and type 2 diabetes, and they found that there was a 1.3% reduction in A1C across the board. Additionally, these patients do lose weight. So in the same cohort, there was a 19% total weight loss. So very encouraging. This is currently in a U.S. Pivotal study. Moving on to mucosal resurfacing, and this is essentially a hot water balloon that ablates the duodenal mucosa. No implant left behind, so that could be an advantage. There was a single-center, single-arm study out of Santiago, Chile, looking at very poorly controlled diabetics, A1C of 9.5 with overweight and class 1 obesity here, not terribly obese. And the A1C improved by 1.2% at 6 months across the entire cohort. And this persisted after mucosal healing was documented on biopsies. However, if you look at patients on stable background medications, they had a 1.8% reduction in A1C. The Revita 1 trial, which is a multi-center study in Europe and Chile, very similar baseline characteristics, and again, you saw improvements in HbA1c, but also in HOMA-IR and liver tests. And what was unique here is they also looked at MR hepatic fat fraction and found a 30% lowering of relative fat and a 6% reduction in absolute fat. So very interesting early results looking at the liver disease as well. They followed this up with Revita 2, and this yielded mixed results with those expected results out of Europe. However, the Brazilian study sites did not do as well. So we are now starting a U.S. clinical trial, and we'll hopefully answer some of the remaining questions. And here we have our spectrum of therapy ranging from pharmacotherapy through our FDA-approved gastric procedures onto surgery, with hopefully some of the small bowel procedures on the way. In conclusion, EBMTs are proving to be effective and have an important role in the treatment of obesity. These therapies may also hold promise in the treatment of type 2 diabetes and across the spectrum of fatty liver disease. And I believe the keys to future success are in combination therapies and a personalized treatment approach. Thank you for your attention.